Good evening, everyone, and welcome to this Scan.com webinar. It's our March webinar, and we run these mostly every month. So if you've never joined one before, welcome. If you have, welcome back. Tonight's session, we're going to be asking our radiology team. So really happy to have Dr. Khalid Latief and James Keane with us this evening, who are actually our very own team, and they've given up their evening to come and talk to you about all things radiology, all things scan.com. Thank you so much to everyone who submitted a question when they registered for the webinar. So this is a quick roadmap of what we're going to be talking about. So we'll have a quick introduction to our speakers, and then we're going to run through choosing the right scan, how to write a good referral, what that looks like, some report language that you guys asked for some clarification on. We've got some example cases and scenarios that you might have encountered in your practice, as well as some imaging advancements in AI. Spoiler alert, James was actually at a conference recently talking about all of these different things, so we'll come to him to share some of those insights. And then obviously we'll have questions at the end. For those of you who don't know about scan.com, we are an imaging platform with over 250 centres across the UK, and we're also in the US as well. And one of our key benefits is that you don't need to have IRMA training to refer to us. We have our own clinical team, of which Khalid and James are on, who help make sure your patients get the right scan. So if you think a patient needs a scan, you can refer them to us. We make sure that everything's sound and we get them the scan they need as quickly as possible. And then we share the results back with you really quickly online, so there's no chasing or hassle on your end. So if you would like to try our free referral portal, there'll be some details in the follow-up email to this, and you can ask any questions about that as we go as well. So our speakers, I was going to come to you guys to introduce yourselves. For those of you who don't know me, I'm Lily. I'm on the marketing team here at scan.com. I've been here for 4 years, so since the early days, but not as early as Khalid. So maybe you want to start us off, Khalid, with your intro.
Yeah, thank you very much, Lily, and thank you for organizing this seminar. I think these are really very important part of scan.com philosophy. I'm a radiologist, consultant radiologist based in Nottingham with interest in musculoskeletal imaging and a co-founder of scan.com. I also work, with other private hospital providers in Nottingham. So that's me basically in a nutshell, really. I don't want to go on too much about me. As you can see the bio there. Been consultant radiologist for longer than I can remember. But yeah, so happy to be here and happy to help out with any questions that anybody has. Thanks.
Thanks, Khalid. I think it's also worth mentioning that you're one of our clinical co-founders, right? So you were day one, scan.com.
Yes, that's right. We founded scan.com. I think 2017 is the time when we decided that this was the thing to do. Myself and Jasper founded the company at that time. So I am one of the co-founders.
Lovely, thank you. And James, do you want to give us your introduction as well?
Yeah, sure. My name's James Keane. I am a radiographer originally, like everybody else. Did my degree and went straight into the NHS, doing plain film in a busy general hospital. Worked there for a few years, moved into MRI. Worked in MRI in particular on mobiles with Alliance Medical. I've worked in the academic sector at Oxford University, doing research at the John Radcliffe facility there called AVIC, the Acute Vascular Imaging Centre. I've worked in statics and mobiles, in MR, in plain film, and then moved into kind of service design and how we can implement that with technology in particular. And that's how I come to be at scan.com.
Great, thank you very much, guys. So we'll get into the questions, we'll get into the nitty-gritty. So one of the core themes of the questions that we got from the audience today was about choosing the right scan, knowing which scan to choose for which symptoms, how to reach a conclusion of what to ask for. So first of all, is there kind of a methodology in your eyes to run through which scan for which area of the body and what the best procedure is to get the answers for example, here, bony pathologies, soft tissues? Are there any scans that are never really appropriate for something and always appropriate for another? Do you have any guidelines on that front?
Yeah, so I mean, it's a wide question. There's a sort of wide field there, isn't it? With all that. I mean, the question is, what do you need to know? What's the problem with the patient? So, for example, bony pathology, if they've had a trauma, for example, you're looking for fracture, the simplest thing, and we always do, is an X-ray of the affected part of the body. So, they might have, fallen off and broken the leg, for example, a hip fracture. An X-ray suffices. And that's the best way of looking at fractures. It's the easiest way, it's the cheapest way, and it's the, only thing you need to do on those patients. If you want to, for example, if the patient's had, say, for example, trauma, and let's say they've had a spinal injury, for example, so you might do an X-ray, but an X-ray may not pick up the subtle fractures that you sometimes see in trauma. I do a lot of trauma work in the Queen's Medical Center. So pretty much the current trauma guidelines are that everybody has to have a CT, whole body CT scan, which would include, the spine, for example, as well. So you look at the spine, you look at the fractures, and if they've had a very bad spinal injury, and if they've got neurology, for example, which a lot of patients do because they've injured the spinal cord, you want to know what the spinal cord injury looks like, where it is. And for that, for the soft tissue details, you would need an MRI scan to look at the cord, you look at the soft tissue, the ligaments around there as well. So that's what you would do in that scenario. So, I mean, do you have a flow chart? Is that, I mean, I suppose, we do have a flow chart for trauma radiology, the on-call, yeah. So MSK complaint, is that, ask yourself, what's the primary clinical question? That is the thing to do, isn't it? What's the question? Has the patient who's had trauma that I've just described to you, the road traffic accident, for example, have they got neurology? If they've got neurology, then you need to do an MRI scan of their whole spine to look at where the injury might be. It will also show you the bony pathology, the contusions that you get with trauma. Definitely the MRI shows soft tissues, the tendons, and, joint internal derangements as well. So it's what you want to know. What's the history? That's really the bottom line.
Yeah, there's quite a lot of detail here, but we can share these slides afterwards about different points to refer, for example, when you might consider X-ray over ultrasound or MRI.
Yeah. So, for example, you've got here, for example, if the patient's had a query fracture, as I said, you do an X-ray. If you've got a patient with suspected arthritis, for example, you would do an X-ray of the hands, for example, looking for any osteoarthritis or any degenerative changes, loss of joint space you get with osteoarthritis, also within the knees and hips, for example. If, however, you've got a patient who has, for example, what we call inflammatory arthropathy, this is rheumatoid arthritis, and they can have sort of inflammation of the joints, of the soft tissues around the synovium of the joints and the tendons. In that case, you could do an ultrasound scan, which is really very good for soft tissue detail. You put Doppler on there and you can see the inflammation. I've just done one patient just now who came to me with a swollen finger, just a middle finger interphalangeal joint. And that's the only thing she's got swollen. And she's been sent in by the hand surgeons for an ultrasound scan. And she had florid synovitis, some inflammation of that joint. But in addition, on the ultrasound, I could see that there was degenerative change, some osteophytes, some new bone formation. So it's a bit of a quandary because with osteoarthritis, you do get inflammation, but not quite as much as that. And my report suggested to the clinician that, have you considered inflammatory arthropathy such as rheumatoid arthritis? It would be very unusual for rheumatoid to affect only one joint. That one joint can be affected in conditions such as psoriasis, for example, but this patient didn't have psoriasis. So it's a problem. So we solve problems for clinicians. So what are the questions we have? So as I said, for tendons and muscles, if you've got a patient who, for example, comes along with a lump, a lot of my practices, patients, usually ladies who have, who often lost weight and they come with a lump in some part of the body. It might be around the abdomen or around the shoulder, for example. You want to assess that lump as to what it's made of. One thing you don't want to miss is a soft tissue sarcoma, which is a malignant type of tumor. So you don't want to miss that. You want to get that as quick as you can. But most of the time, fortunately, most of the time, these things just turn out to be lipomas, fatty tumors. And you can do an ultrasound scan on them, and most of the time that suffices. They're quite small, and you say, don't worry about it, go away, forget about it. If you want an operation, go and see a surgeon, and they'll take it out for you. With the ultrasound, however, you can sometimes see that the lesion is not a fatty lump. It's got some other tissue elements to it. It's got some blood supply to it. And that makes you think, actually, this is more nastier than a normal, simple lipoma. And then you go and do an MRI scan. The other thing the ultrasound is very good at, and we use it for, is to differentiate cystic lesions from solid lesions. So if something is a cyst, fluid-containing cavity, it's nothing to worry about. You can reassure the patient that it's just a simple cyst, nothing to worry about. Other conditions that we use ultrasound for, soft tissues, are things like plantar fasciitis on the ankle, around the plantar fascia. That's as you get older, like I do, you get plantar fascia pain, and you can diagnose that. Look at fluid and so on. The other thing that we use ultrasound for is image-guided injections. So we can guide the needle into that joint that's inflamed. For example, in this lady, she would probably need an ultrasound-guided injection of steroid into the joint. And we can do that with ultrasound guidance, see the needle going in real time. So that's the sort of things we use ultrasound for. MRI will show you all those things as well. But of course, it won't help you with the guidance of the needle into the joint. Any other things that we need to consider ultrasound for?
There was one question regarding MRI.
Yeah.
Mindy has asked in the chat, what's the difference between an MRI and an MRA, and when would you request the latter?
Yeah, so basically, I was speaking to Lily earlier on. I've just done 2 MR arthrograms this afternoon, one of the hip and one of the shoulder. And so let's take the shoulder, for example. So if you do a regular shoulder MR examination, you'll see the rotator cuff, you see all the soft tissues around that, but you will not really see the glenoid labrum, to which attaches the biceps to the superior labrum, biceps tendon. And often with people who dislocate the shoulders, that they damage their labrum anteriorly, what we call a Bankart lesion. So you probably will not see that on a regular MR examination. So what happens then is that the surgeons ask us to confirm that the patient has a Bankart lesion, i.e. labral tear. So we then inject them with contrast aseptically under guidance. We put the needle into the joint space, in the shoulder or the hip. We confirm that we're in the joint with the X-ray guidance, or with some people do with ultrasound, but my preference is on X-ray guidance. And once we're in the joint space, we'll confirm it with contrast, i.e. X-ray contrast, and then we'll distend the shoulder with some contrast material that the MRI will see. In our practice, we used to use gadolinium in the joint, but nowadays we just inject them with saline, about 15 milliliters of saline. Once we've done that, we take the needle out, the patient goes to have an MR arthrogram in the MR scanner. So we have a specific set of sequences for the shoulder or the hip for the MR to look for that pathology that we want to diagnose, i.e. a Bankart lesion or a SLAP lesion. labral tear that happens with the bicep tendon attaches. So that's the difference between an MR arthrogram, because MR arthrogram is two-stage procedure, the intervention part and then the MRI part, whereas MRI itself is just one part. You just lie in the scanner straight away. Okay.
Great.
Any other?
I think I might shuffle on from here as we've got some additional questions. So if we move on to referrals, and this is another topic that we had a lot of interest in, a lot of questions about how much information is too much information and how little information is too little information. So keen to understand what you guys look for in a good referral. So here are some questions that we received about that. So yeah, the pertinent info needed. Also, would you recommend a different scan if you disagreed with the referral reason? And then a question for you as well there, Khalid, which we can come on to afterwards, about the challenges of interpreting with limited information. So to start with, could you tell us about what you look for in a good referral?
I think, as I alluded to earlier, I think the most important point is the history of the patient. I often get a referral with, knee MRI, and I really need to know why you want a knee MRI. It might be knee MRI pain, but I mean, it's really critical to know that, have they had any injury, for example? If they've had an injury, what were they doing? What was the type of injury? Was it like playing football, pivot shift? Was it a skiing injury? Because as a radiologist, I really need to know, because I can figure out what type of injury they've had. And from there, I can figure out what findings will be on the MRI scan. So it's really important. And, if they've got pain in the knee, tell me where it is. Is it in the front? Is it in the back? Is it on the lateral side? Is it on the medial side? Because we've got this global image, whole set of images, and we've got lots of findings on them. And then we've got to make a decision as to which ones are those findings important for the clinician. So I always say to the clinicians, if you want a good report, give me good clinical information and what you want the clinic. What's the clinical question? What's the question you want answering? And that's what makes a very good referral. And we don't want masses of writing, because then it's difficult for us to decipher. Like with anything, you're going to switch off and say, oh, not another one of those when it's 6 pages of clinical information. I don't really want to know the patient's got a cat or whatever, unless there's a relationship to that. So an important part is, we want to know what you want answering.
I think I'd throw in
Yeah.
personal and clinical history in there as well. If certainly as a radiographer, but I think the radiologist as well, we don't typically have access to the notes, or won't have seen the notes. We don't have any kind of history. If the imaging was done elsewhere, we won't necessarily have that either to refer to. So very often we're working almost completely from just the referral form. So if you've sent the patient for a chest CT and they've had a lobectomy in the past, we don't know that unless you tell us.
Yeah. And I often, I don't know who's on the call, but I often look at an MRI of the knee and I look at it and I'm thinking, that meniscus is kind of gone. It's either been taken out or it's torn, de novo. And you can sometimes know that they've had, arthroscopy and a resection of the meniscus by some of the changes that you'll see on the Hoffa's fat pad anteriorly. But, it would be so nice if they said to us, oh, the previous partial middle meniscectomy, and that makes it so much easier for me to report my scans.
Would you say that there are some common challenges you face then with interpreting with limited information? Do you find that you would clarify that information when you said, the quality of the report can come down to the quality of the notes as well?
Yeah, it's all to do with that. I'd say, so really, as Jim was saying, we are sort of if you don't get the pertinent clinical information, we're blind. I've got a friend of mine who was an ankle surgeon up in Yorkshire, and he said to me once, he said, it must be really difficult for you to report ankle scans. I said, why? So, well, you don't know what you're looking for because we don't tell you the right information because he's obviously a clinician who's reversed stuff through. Because, for example, an ankle is a complex joint. It's got tendons on the lateral side, middle side, anteriorly. It's got ligaments. It's got joints. It's got bones. So unless we've got this proper clinical information, we are really in the blind. Yeah, but I think that's what your question is, Lily, isn't it? I think I might get it wrong or not, but we do need that really important clinical information.
Yeah, definitely. We've also had a question from Bob. How important is it to mention pregnancy in a referral for an MSK condition? I suppose there's lots of different scans that could be done for MSK, so it may depend on the scan type.
I think I'll get James to answer that one.
Yeah, that's one for you, James, I think.
Yeah, sure.
Meet first patient who's pregnant.
I mean, I guess there's always the thing about the referrer being kind of responsible for making sure the patient's safe, and it falls back into the same kind of discussion, really. Anything that's pertinent to the exam that they're going to have is ideally would be communicated to the team that are going to scan that patient. In my experience, everywhere I've ever worked, radiographers are always very, very diligent about that patient safety stuff. So plain film, we're always going to be asking patient safety questions. Similarly with MR, anything that's cardiac pacemaker, injuries, bullet wounds, shrapnel, all of those types of questions, that spiel, everyone radiographically is always going to ask those questions. So that kind of safety thing, there's such a sort of double safety net there. I would say if for an ankle, for a foot, for a plain film X-ray, the radiographers not going to be overly concerned. If I was to be asked to CT abdo on a patient who turned up 7 months pregnant, then people are going to sort of roll their eyes and go, why didn't the referrer think to tell us?
Yeah, I mean, I think pregnancy is really, really great. I mean, we had one this afternoon. Lady's in the mid-50s, but I think we have to ask that question apparently until they're 56. Could you be pregnant? And it's really important that you mention pregnancy is very important. You mentioned that, yeah. But as James says, for that scenario, we always ask them that question anyway.
So we'll move on to the next slide, which is specifying views and protocols. And I'm sure between you guys, you'll have a lot of insights here about whether or not it's the referring clinician's responsibility to state the views that they would like. Do they leave it to you? And does it get in the way if they give you an angle that is or isn't required?
If I can,
for James as well. Thanks, James.
Yeah, I'll jump in. So there's a number of kind of factors here, I suppose. I mean, first up is that under Irma, the referrer's job is to provide enough clinical history so that the radiology team as a whole can justify the exposure. They are going to then answer your clinical question in a way that is most appropriate and which minimizes the radiation exposure, and that's their job. So with that in mind, it can sort of irk radiographers, I guess, when someone is ultra specific about the views that they want, and you see referrals coming through for a knee, and it specifies very particularly AP and lateral. You're like, of course it's AP and lateral. I guess it's deciding on the views for plain film or deciding on the specific pulse sequences for MRI fundamentally comes down to the radiology department's expertise. And I suppose I could liken it to sort of if a GP was to refer to a physio and then specify very particularly what exercises they expect to be given to the patient to do. It's a kind of a scope creep, I suppose, that's probably not appropriate under Irma. As operators and practitioners, the radiographers would know to include that every time. If it's more bespoke, then again, ask for it with an appropriate clinical question. So if you say, knee, please, plus skyline patella, without any reason why you want the skyline patella, then you might get it. You probably shouldn't. If you say, I'm assessing patellofemoral space, then you shouldn't need to ask for the skyline, because any radiographer worth their salt would know to include the skyline. So that's what I say. If the clinical history is good enough and your clinical question is specific enough, then you shouldn't need to worry about what views to ask for.
I think yeah, you're absolutely right, James. I think the thing is that what clinicians have to realize, and they do realize, the people that I work with, is that the radiologists are there for consultation. So, for example, if they don't know what they exactly want, they will come down to the department, have a chat with us, or email, and then we can put them in the right direction. If I get a request and I think it's inappropriate or completely wrong, then I will reject it, and I'll tell them why I rejected it as well. And then they might get a bit upset, but then, I have the right to do that, under IRMA and that sort of stuff. So, from my experience. So, yeah, I mean, I think, but yeah, most of the time, they get it right. But as James says, that, we decide what the patient's imaging requirements are in our departments. So, you might want whatever you want, but we might decide that that's not an appropriate examination for the patients, and we won't do it. We'll do something else.
Cool. So we have a bit of a checklist here that summarizes what we've talked about just now. So the clinical question is really important, being specific about what you think you might be looking for. But also, as you guys have just said, with regard to views, but also with modality, and I mentioned it at the top of the call as well, we have you guys, thankfully, and our in-house clinical team. So when any of our viewers are referring to us, we have the team to help make sure that the patient gets the right scan. So even if you're not sure, it's worth just writing in your referral notes, and we can take a look and help you get to the right modality and the right views and all that kind of stuff. One question we did have, which was in the questions that I received before the call, but I think it's relevant to bring up here, are red flags, because there may be times where, waiting for an imaging scan is not the best thing to do. Like, it might be a very urgent situation, or, noting if you think something's urgent, but you're not sure. I mean, key ones we had were for lower back pain and hip. So could you guys speak about that in terms of what to do with red flags, to put them in a referral or to take another course of action?
I think yeah, just take this one briefly, James, and you can chip in if you want anytime. One of the things in lumbar spine or spinal imaging, for example, red flags are, as you put down there, patient has back pain continues at night, they've got fever associated with pain, they've got a history of maybe malignancy or cancer somewhere. So those are the sort of things that are red flags that you really shouldn't wait too long for, including with spinal imaging, so they've got it's got bladder and bowel dysfunction that's, occurring as well. They shouldn't wait. And I think for those sort of patients, I think they should go straight to A&E, actually. I know that scan.com, we provide, great imaging, timely imaging, and we've picked up these patients who waited and come through our system that we've referred on to the local A&E departments in the past. But if you as a patient have got these red flags and you've got spinal problems, then really you should go straight to the A&E department.
Great, thank you. So we'll move on now to understanding reports. There was some radiology language that our viewers submitted that they would like some extra information about. So a few of these come down to the role of the radiologist and the radiology team generally. I think if we start with the bottom question, because I think it applies to both of you in terms of during a scan, why can't you tell the patient what you're seeing on the screen, or why can't the radiologist tell the patient straight away what they've seen? Why does it tend to go through a GP or a kind of clinical chain of clinicians in terms of reporting?
Right. So let me just take this one. So for example, when I'm so my patient contact is usually when I'm doing ultrasound on a patient. So for example, abdominal ultrasound or a joint ultrasound, whatever. And actually, I talk to the patient and tell them what they want to know. So they often tell me, Doctor, will you, sometimes they say, Doctor, will you tell me what's wrong with me today? I say, yeah, why not? It's your body. I'll certainly discuss it with you, no problem at all. So that's my practice. I will do that when I'm there with the patient, they want to know. There are some patients, however, don't want to know. So you've got to make sure you don't tell that patient what's wrong with them because they're scared, aren't they? But most of the patients are very happy to know what's going on when I'm ultrasound is scanning them. So I tell them straight off, and then I say to them, "This is what I will tell your GP. I will send the report to your GP, and I will tell them what I found." So they're really very grateful for that information. If I'm reporting remotely an MRI scan, I've got an MRI scan of knee on my screen here, for example, patient was scanned 2 days ago. It's difficult for me to discuss it with the patient. It's come from a clinical clinician, an orthopedic surgeon. So it's the job of the orthopedic surgeon to whom the patient belongs to who's looking after, to tell the patient what the pathology is, what the abnormality is going to be, because he's going to manage it further. If the patient was here, then I could definitely talk to them, give them the management scenarios that are possible. But that's not my expertise, is it? Surgery, for example, in orthopedics. But I can certainly help out, no problem. But when it's ultrasound, I'll certainly tell them that.
Dr. Khalid, one of the things that I remember radiologists telling me in the early days of being a radiographer again was as a mantra that the radiologist reports the films, not the patient. That very often that the workflow in a radiology department means that you're seeing the film several hours after the patient's already left the building. And again, as I say, all you've really got is the referral form and the images. And so to kind of venture an opinion on the patient's kind of wider well-being would be inappropriate because you've just got no evidence. You can really only see those pictures that you've got.
Yeah. I mean, so my scenario I was talking about was patients there with me. They're asking the question, I'm doing ultrasound on them. Most of the time, patients not here with me. That's why we can't tell them anything.
From the point of view of a radiographer, I mean, obviously the classic thing and the thing that we'll all very readily fall back on is we're just radiographers. We're just we just do the pictures. We can't tell you anything. Is obviously we're not medics. We're not surgeons. We're not. Most radiographers aren't reporting radiographers either. But even ones who are will often demur from giving any kind of an opinion to the patient on the day. Because very often, I mean, a radiography department is a busy place. You've got multiple patients coming and going. You've got the phone ringing from the wards or from wherever. So to kind of glance at a picture and say categorically to a patient, here's an opinion, would just be totally dangerous and inappropriate.
Well, I totally agree with that, James. I think that time is so critical, isn't it? So we're so busy. We just haven't got that sort of for example, if I found a cancer in somebody, I'm going to have to speak with them, spend half an hour, 40 minutes with them, counseling them, all that sort of stuff. So really, you got a big list of 10 patients to scan, and then you get this finding, and it's not it is your responsibility, but not your responsibility, because it becomes very difficult then to pass the message on to the patient. So it's easier for the clinical team to do that, because that's what they're there for.
The only caveat I suppose I'd put onto the end of that is that radiographers, radiologists, of course, we do absolutely know what we're looking at on those images, and we will then tailor our imaging approach kind of reactively to what we're seeing. So if we've seen something that looks possibly malignant, we will then alter our technique and make sure that that's covered and shown. So we may not tell the patient anything, but we'll be making sure that the pathway is swinging into action behind the scenes.
So what I do, so say if I found something, say, let's say, for example, I'm ultrasounding somebody and I found a lump in the liver or something, and I'm not sure exactly what it is. I just tell them, look, something in the liver here. I'm not exactly sure what it is, although I've got a pretty good idea what it is, But I would need further imaging, for example, a CT scan or an MRI scan. And I tell the patient that this is what we would do in normal practice. This is what we're going to do. And patients are so grateful for that. And so I'll send that report to clinicians. And often I will book the CT scan or MRI scan for the patient while they're in the department. So they have a date for them to come back for that. So, the patient's not surprised when they go to see the GP saying, I've got to have another scan. I didn't know that. So they're informed already why they're going to have another scan. There's another question, is there, Lily?
Yeah, so I think the other questions here can kind of be summarized in terms of how important is the actual scan image itself versus the radiologist interpretation.
Well, so just go back to ultrasound. The ultrasound imaging is done on the day by the radiologist. The images don't really mean anything to anybody else because I can take lots of pictures of somebody's abdomen or whatever, but it means nothing because it's real-time imaging. So that is important to be done by the radiologist who's done the scan and reports it at the same time. Other images are, I think it's best that the specialized radiologist reports the imaging. Then you're going to get a more specialist type of report. That's going to be more useful. I'm not saying that non-specialist radiologists can't do it, but I just think you'll get a better view of it from that point of view. There's a question about outsourcing here. I think a lot of our images are outsourced nowadays because we have shortage of radiologists. And some of the outsourcing reports most of them are very good, but some obviously fall short of the standard that we would like them to be. However, I mean, I think that's because people are under pressure in reporting and so on. I think that may be one of the reasons for that. So that can happen in outsourcing and in also insourcing, people working in the hospital as well. So I think, in summary, I think a specialist radiologist should report that scan. So, for example, if I'm a GI radiologist, I should report livers and I should give a specialist report on that. If I'm a MSK guy, I just do their MSK stuff and so on, really.
I think that's where outsourcing can, potentially be a good thing.
Yeah.
Obviously, with the workflow the way it is, as ultrasound apart, the patient and their images, or the images, not the patient, are going to be reported, out of context anyway. And in which case, a good outsourcing group can mean that those images are going to get reported by someone who is, a really, really specialist at, pediatric MSK, for example, rather than, just whoever's on call in the hospital.
Thank you. I'm keen to keep moving because we have some example cases, or I think they were quite popular in terms of the questions. So perhaps if we could do a quick kind of rundown on signal intensity and difference between T1, T2, and STIR, and then we'll move on to some questions about specific images.
Without going into the physics of how any of these are required, because I don't want to waste everyone's time with that. We can do another call on MR physics if people are super keen another time. But basically, it's you're going to see different things on these different weightings. So a T1, you're going to see bright fat. You're going to see sort of dark fluid. Muscle is going to be a sort of a grey colour. Yeah, well, we can see on screen. Whereas a T2, you're going to see brighter fluid and lower signal muscle. There's a lot more going on that T2, so this is where like a STIR comes in, and a STIR is going to be very, very sensitive to fluid. And I think there was a question I'd seen in advance of this talking about sort of stress fractures and maybe occult fractures, and that stir and fat saturation techniques in MR can add a lot of sensitivity to edema in particular. So if you're looking for any kind of microtrabecular injury, a stir or fat saturation techniques, proton density fat sats are going to be really sensitive to picking up those types of things, and you'd then typically ally them with a T1.
Yeah. So yeah, excellent, James. I think these images are very nice. I think basically the way I look at it, I mean, as I say, MRI physics is another kind of chapter really, and it's beyond my understanding nowadays. I know basic MR physics, but it's quite hard stuff to. The way I look at it is T1 is really good for anatomy, as you can see here. I'm sure you'll agree, James. And then the T2 or the stir images and the stir images, which include fat suppression, are good for pathology. So that's basically what they're good for. And then the question about Lily, I think somebody said, I want to understand modic changes often reported in MRI scan. So those are the changes. Dr. Modic, I think, the American radiologist, described them in spinal imaging, and they basically stress reactions between the vertebral bodies, and you got type 1, type 2, and type 3 modic stress changes. Type 1 basically edema it starts off with edema of the bone marrow, so it'll be sort of low signal, i.e. dark on T1 and high on T2, and type 2 basically fat on both T1 and T2 signals. So it'll be bright on T1 and bright on T2. And type 3 is basically sclerosis. So it'll be dark on all sequences. So those are the modic changes on MRI. It just means that there's response, there's degeneration.
So we'll move on now to some example images. We had a few different questions about specific stress fractures was actually one of them, and we've covered that a couple of times. But we'll start off with best method of imaging for a shoulder in general. This is a kind of illustrative image that we've got an X-ray, an MRI, with stir. Could you give us your lowdown on that?
Yeah. So I mean, imaging the shoulder, like most joints, I think you start off with an X-ray. It's really important to do that, because it gives you a lot more. And you'll see some calcification in soft tissues, for example, which is more difficult to see on MRI scan. So on here, for example, on image A, you've got an X-ray of somebody who was an athlete, I think. Is that right? Yeah. Athlete, elite diving athlete. So they probably go like that they dive in with their hands, and on the right two images are stir images. There's a coronal image on B and the axial image on C. And you've got these bright areas. Can you see the bright areas in there? There we are. So that's basically a stress response, stress fracture. They've not fused their epiphyses. Quite a young patient, I think. So they've got traumatic growth plate injury there. So this patient would need rest. Otherwise, they're not going to do too well. So they bang the growth plate like this while they dive down.
Would you say that MRI is the gold standard? Is it the most common thing you use for shoulder, or does it really depend on the case that you're looking at?
Yeah, it depends on the case. So I guess if you're an elite athlete, you're going to end up having MRI straight off. And if you're looking for bone pathology, like contusion, like this case, then you do need an MRI scan. That would be the best examination. But yes, gold standard, I would say, for bone pathology.
I think the shoulder is much like the ankle. It's a very sort of three-dimensional body part, and it can be quite difficult to image. I think in particular with plain film, an axial shoulder, AP and axial would be kind of typical that you'd try and get. But to get a good axial shoulder, you're having to get the patient to fully extend their shoulder, sort of lean over the edge of a table, get their head out of the way. It can be very difficult and very painful for patients who have shoulder injuries. Obviously, they will do because that's why they're there. So sometimes the imaging that you can get is just inherently it's constrained by the capabilities of the patient.
There's always a question, if you're going to do an imaging examination, will that alter your clinical management? That's the question that you've got to ask yourself. So in this scenario, for example, an elite athlete, and it will alter the management because you're going to stop them from training. If this is some regular Joe public down the road, he's got shoulder pain, he's hurt his shoulder, but there's no fracture there, there's no point doing an MRI scan. You wait for them to get better. 6 weeks down the line, they're going to get better. You're going to save yourself an imaging slot and MRI scan, So it wouldn't make any difference to that other patient, but in this case, it would make a difference.
Absolutely. I think we're coming on to another shoulder-related question, which is how necessary is imaging in diagnosing frozen shoulder? And this is a case here, a 40-year-old female, 4 months history of painful right shoulder with restricted range of motion.
Yeah, frozen shoulder is one of those conditions that I deal a lot with, actually, and really it's a clinical diagnosis. So if you're a shoulder surgeon and you can make you should be able to make a diagnosis of frozen shoulder and then treat it without imaging. But I sometimes get patients like this who the clinical information is not necessarily frozen shoulder, but just shoulder pain. And then I'll see some changes on MRI scan, like you pointed out there, some changes in the rotator interval, some high signal there, and also in the axillary recess, some high signal there on the T2 images. You can make a diagnosis we can suggest the diagnosis the patient may have frozen shoulders, so the clinician can go back and then examine them again. So I think, they've got frozen shoulder, so correlate with the MRI, it works well. But frozen shoulder is kind of a limiting, it gets better by itself usually. We can treat it. I often treat it with what we call shoulder hydrodilatation. So what I do is I inject the shoulder with steroid local anesthetic, and I inject sort of 40 to 50 milliliters of saline inside the joint to distend the capsule. And actually, these patients do really well. It's often the patients with diabetics that get frozen shoulder.
We're now moving on to what's been a popular topic, which was the bone stress reaction and stress fractures. What imaging would you recommend for these cases?
As you've just shown there, you start off with an X-ray, and quite often the X-ray is normal, although in this case it's abnormal. You can see the stress fracture line as pointed by the arrow. There's the sclerotic line, and that's a classic appearance of a stress fracture on an X-ray. MRI, which you can see on the right here, shows this sort of low signal line with bone marrow edema around it. On this, it's a T1 weighted image, this one actually. So you can see that the bone marrow is bright, it's full of fat, and then you've got a break in it, which is that line that you're looking at, which is the stress fracture. MRI is the best investigation for stress fractures. For any stress fracture, see them in the hip, from the ankle, in the shoulders. James, do you have anything to add on about stress fractures?
Not about stress fractures. I think we've really covered it. Obviously, the fat saturation techniques in MR give us very good sensitivity for microtrabecular changes. I mean, it's been a very long time since I've worked in a play and film department, but there was always a move, really kind of constrained by the availability of MR, but to move scaphoid imaging for occult fractures, rather than running that sort of a 7 to 10 day delay on plain film, just to moving those straight to MR if it was available, just because it's so much more sensitive.
I was talking to a company that's supplying our scanner, and they do a small scanner, which is the extremity scanner. So a lot of trusts are buying those scanners so they can get them off the wrist, the small sort of joints that are off the main scanners into these scanners. So look for stress fractures. Save that time for the patient and for the clinicians.
I think this is our last question on cases, and then we'll wrap up with technological advancements. We may run a few minutes over, but we're doing well for time so far. So could you talk through types of X-ray that are best for hip dysplasia? And then there's a couple of different views here.
Yes, that's right. Frog leg lateral is one we use for slipped upper epiphyses of the hip. That's the best examination for that. And yeah, so just AP views, and here you can see the dysplasia on these patients. I think an X-ray is by far the best examination for these questions.
Just before we move on to the technology, about do we do MRIs on patients with pacemakers?
Yes, so we do have James will come in on this one. So we do have conditional pacemakers nowadays that are fitted in. They are MR compatible, but they have to go through the cardiac technicians have to assess them first. They have to be there at the time the MRI is going to be done, because they have to do some tweaks to the pacemaker. So it's not like, pacemakers are okay now, you can go on MRI scan. So it's got a whole lot of stuff to do go along with that.
Yeah, exactly that. And I've had these arguments in real life where patients or their clinicians have said, "Oh, it's an MR safe pacemaker." Well, maybe, but I'm on a mobile scanner in the car park of a general hospital, and I just can't risk scanning a patient just on the basis that they've got a pacemaker, which may be MR conditional. There'll be there's a lot of variables about that.
Yeah, so I mean, in my experience, I think they're all these patients are done in a hospital environment rather than a mobile scanner in the car park, as you say. A lot of patients are scanned in mobile scanners.
So we're on to our last section now, which is about technology advancements in imaging, everything from AI to new machines, color images. Obviously, AI is a topic of conversation a lot at healthcare conferences and just in general, any industry. So I was wondering your guys' thoughts on these questions. So
Color images, well, it depends what scan you're talking about. So I think MRI, I don't think they're worth the investment right now for color images. Let's take that from off the agenda. Certainly 3D images, ultrasound, you can do 3D imaging, 4D imaging as well, actually, especially for baby scans. James is going to talk a little bit about AI, aren't you, James? Is that possible?
I can talk about AI. I suppose, just to reiterate what you said with color, just from an MR point of view, I guess. I mean, obviously, color in radiology tends to add, I guess, an extra dimension to the imaging. So you'd be looking normally at raw anatomy with in black and white. Any kind of attempt to use colors just tends to add busyness, which really makes it very difficult to discern anything from the images. But then and obviously Doppler ultrasound is a great example where you can then say, okay, there's a physiological component that we're going to overlay here, and that's where color does have its use. 3D, and again, speaking from an MR point of view, 3D techniques in MRI are pretty common now. And you're usually acquiring slices or the equivalent of slices in a Cartesian plane that would be used to sagittals, coronals, whatever it might be. But you're acquiring data at sort of such density that you can then recreate that tissue in any plane that you want to recreate it in, sort of by way of post-processing, I suppose. And I think that can be very useful, and it's not noticeably more time consuming to do that these days than typical slices. So yeah, I mean, 3D techniques in MR are really common. AI wise, obviously radiology has been a really, really fertile area for AI development for a very long time. And I have conversations, if people find out what I do, if we're, having a beer together of an evening with some friends, they'll be like, "Oh, I've been thinking you could put a chest X-ray through ChatGPT, and that would be revolutionary." Like, yeah, no one's thought of that yet. Um, and obviously, this has been going on for over a decade. People training algorithms. The the classic barrier is that it's easy. It's not easy, but relatively easy to train an algorithm to be very good at one thing. So you might train an algorithm that's very, very good at looking for lung mets, but on that chest X-ray, you're also looking for pneumothorax, and you're looking for infection, and you're looking for any number of other things going on at the same time. And so then you end up having to run 3, 4, 5, a dozen different algorithms, each of which is trained to look very specifically at that one pathology type. Now, looking in the MR and looking at what's really, really big right now, at ECR a few weeks ago, there were umpteen brain packages, so much brain AI, and I know of 2 or 3 that weren't there as well that are very good. But each of those brain packages perhaps has half a dozen different algorithms looking for traumatic brain injury, looking for physiotherapy and multiple sclerosis plaques, looking for brain aging and dementia, looking for signs of stroke. There's each of those then comes with a fee, and none of them replace the radiologist. I think, and Khalid, you can correct me if I'm wrong here. I think that AI is finding its niche now, really as a kind of a co-pilot for the radiologists, and instead of a radiologist being able to do, I don't know how many scans you do, 20 patients a day or whatever it might be, they can report 50 patients a day, because the AI is able to triage appropriately and say, these are the ones that look like they might have something urgent on, look at these first. And it's able to say, here are all of the little metrics that it might take you a long time to measure and use PACS tools to derive, that we've been able to automate that step. But the final clinical report is still always going to need to come from a consultant radiologist. And I think that's going to be the case for a long time.
Exactly, yeah. And I think there's a lot of AI being used now, particularly in breast imaging, where AI kind of reads first, and then the radiologist sort of checks it and makes sure it's okay, and then signs it off. Yeah, but you're right. It's watch this space. AI is here to stay, and will be very helpful for radiologists, definitely. I think it's been a really great session, and I hope you all enjoyed it. Thank you, Lily, for organising it. Thank you, James, for helping me out. Really fantastic. And we watch out for the next one. Hopefully, we'll have another one for you. Thank you very much.
Thank you very much, everybody.
Okay, Lily. Thank you.